Welcome to Beat Cancer, the official podcast of the UC Davis Comprehensive Cancer Center. Thanks for joining us today as we have an in-depth discussion of the science, research, and advancements taking place at our National Cancer Institute designated Comprehensive Cancer Center. I'm Chris Joyce.
And I'm Stephanie Winn. We will also examine proactive approaches to cancer prevention and, most importantly, how we are breaking barriers to beat cancer in our community and beyond. Joining us today is Dr. Andrew Berkland. Dr. Berkland focuses on providing care for all benign and malignant head and neck tumors. He has specialized training and a particular interest in microvascular reconstructive surgery as well as robotic surgery. You're going to have to explain all of this to us, and we look forward to it, Dr. Berkland. You know, head and neck cancers seem to be on the rise, particularly due to a few different factors, but it is Head and Neck Cancer Awareness Month, and that's why we want to focus our podcast today, Beat Cancer, on these devastating cancers, really. Tell us about all the different types of tumors you see.
Yeah, so as head and neck cancer surgeons, we treat, as you mentioned, both benign, that means non-cancerous, but as well as more commonly cancerous tumors that are really throughout the head and neck. So we say basically that's from the base of your skull all the way to the top of the lungs. And so that's kind of the territory of a head and neck surgeon. So commonly this includes the mouth, the throat, the voice box, as well as the nose and the sinuses. And so those are common places where we say we treat what we call mucosal head and neck cancers. That's the lining of the inside of your mouth. We also treat cancers and tumors of the saliva glands. So you have three major saliva glands: your parotid gland, your submandibular gland, and your sublingual gland. And so sometimes people develop tumors or cancers of those glands, and we treat those as well. Additionally, we treat thyroid disease, so that includes thyroid cancers as well as thyroid nodules and other reasons someone might need to get their thyroid taken out. And finally, we also treat skin cancers that are located in the head and neck. Again, there's a lot of intricate anatomy in the head and neck, and so our knowledge of that anatomy allows us to treat cancers like melanoma as well as non-melanoma cancers of the head and neck. So those are kind of all the types of cancers that we treat as head and neck surgeons here at UC Davis.
Well, and do you typically see the head and neck cancers more in a specific population, or is it spread out pretty evenly across demographics?
Yeah, that's a great question. It's really dependent on the cancer type. So, your classic tongue or maybe voice box cancer patient is traditionally an older smoking patient. So smoking is one of the biggest causes of traditional head and neck cancers in the, we call it the upper aerodigestive tract, anywhere from the tip of your tongue all the way down to your voice box. And so those tend to be older, traditionally were men, because men were heavier smokers, and they would get these head and neck cancers. That being said, Stephanie, as you mentioned, there's the demographics of head and neck cancers are changing quite rapidly. And part of that is tied to the increase in HPV, or human papillomavirus associated head and neck cancers. And so HPV is a virus. It affects really most of us in our youth. Most of us do contract some strain of the virus. Unfortunately, most of us clear it. Unfortunately, some of us catch and don't clear certain strains that are more likely to lead to cancer. And this is what's also associated with cervical cancer as well. And so these can cause cancers in the tonsils and the back of the tongue, and so it's actually rising rapidly in incidence, affecting both men and women, and affecting younger patients as well. Its incidence is actually so high, it's actually overtaken cervical cancer as the most common associated HPV cancer. And so this is the cancer that Michael Douglas had, and you hear it, some of the celebrities are opening up about their experience with this type of cancer. So it's certainly on the rise. And that being said, all cancers of head and neck, they're more common than you think. So head and neck cancers are the 6th or 7th most common cancer in the world. And so they are certainly, I think they hadn't up to now been making the headlines, but have been there and pretty prevalent throughout our history.
Well, and I think, let's be frank about it. This is these cancers, some of them, the HPV related cancers of the head and neck, are due to a sexually transmitted disease. But the good news is there's a vaccine. And this can help. This is why our cervical cancer rates are coming down. Do you see them eventually with, the vaccine working effectively to prevent head and neck cancers?
Yeah, that's a really excellent question, and one that so our society actually strongly supports all people, both men and women, getting the HPV vaccine. And so the same strains that can cause cervical cancer, as well as anogenital cancer, cause oral pharynx cancer. And so it's FDA approved for anyone up to age 45. So our society actually supports both men and women getting that vaccine as well. The trick between cervical cancer and the HPV-related throat cancer or tonsil or base of tongue cancer is that the time between the infection and leading to cancer and cervical cancer is shorter, so you can tell a direct effect. The HPV-related throat cancers is really 20, 30, 40 years down the road that their cancers are developing. And then so, we can extrapolate that these vaccines should have an effect. And indeed, we'll probably see, as we're seeing it peak right now, you'll probably see a lag, and then eventually it'll probably decline as more and more people get the HPV vaccine. But it'll just be very hard to prove because that lag period between the HPV infection and then developing the throat cancer. But hopefully in 50 years, I'll be out of a job for needing to treat oral pharynx cancer.
Well, let's hope. For our sake, I don't know about for yours. And I know dentists quite often spot these head and neck cancers, right? I mean, I know my hygienist is actually doing a really good job of looking around my tongue and my gums and the back of my throat.
Yeah, absolutely. I went to the dentist this morning, and I could tell the hygienist was looking closely at my tongue and or mouth. So I silently was applauding her. So yes, absolutely. Oftentimes, patients, well, the most common person who finds their cancer is the patient themselves. They feel perhaps a lump in their neck or an ear pain or have something just doesn't feel right, and everyone knows their body the best. So we take the patient's symptoms seriously, and so something we wanted to dive further, something's feeling something wrong. That being said, yes, dentists and primary care doctors often are the ones who spot something abnormal, and dentists especially as they're looking really readily in your mouth, especially in patients who might be smokers or have known kind of lesions in the mouth. Certainly the dentists are often the ones that might spot that and send them along to the path to seeing a head and neck surgeon.
Well, and you, so we touched on a little bit with just the HPV vaccine, and then you've mentioned smoking. Are there other ways to be preventative in this that patients could be like? Is there, anything that they can cut out of their lifestyle maybe that would help, or things to be on the lookout for? Any environmental factors, anything like that, as far as it relates to prevention.
Yeah, certainly smoking is far and away the most common cause of the traditional head and neck cancers, and we that's one of the most common lines, and patients usually know this, but it just speaks to the addictiveness of tobacco that everyone kind of knows, but it's a hard road to come back from once you start smoking. But certainly we give them whatever support they wish to help stop smoking. So the most important thing from cancer prevention would certainly be never start smoking, but if you start smoking, to stop as soon as possible. Alcohol acts kind of as an enhancing agent with smoking, so alcohol by itself maybe has a little bit of impact on head and neck cancer, but really its addition to smoking can really increase your risk there. And as you mentioned, the HPV virus is one that can cause the tonsil cancer. There's another type of virus, it's called Epstein-Barr virus, and that's associated with nasopharynx cancers, so cancers in the back of your nose. These are more common in Southeast Asian populations, and there's not a vaccine for it, but it is something that people are aware of. As far as other things that we can use that can cause head and neck cancer that we tell people to quit as one is, again, more in Southeast Asia, but people will chew a nut called betel nut or areca nut. I'm actually from the island of Guam, and it's very commonly chewed there. and that we know leads to head and neck cancer. There, as well as some various kind of chemicals, so some woodworking agents, some metals, nickel. Those are less common, but some environmental exposures there. But certainly the big one being smoking, and then that's preventable. And then the other one being HPV, again, now with younger populations, potentially preventable with the vaccine.
And all tobacco use, right? Because chewing tobacco is a leading risk factor as well.
You're absolutely right. So it's all tobacco use, yeah.
What about vaping? I mean, are there studies out? Do we know?
That's a great
where the
question.
risk is with vaping?
That's a great question. It's too early to know, but certainly we know that chronic irritation can lead to airway irritation, can lead to deranged cells, and could potentially lead to cancers. So I certainly wouldn't say it's safe. Same thing with marijuana. There's kind of conflicting studies, early studies, so we don't know 100%, but certainly wouldn't seem potentially safe. And as far as one other preventative, again, is because we do treat skin cancers of the head and neck, and we do see quite a lot of that in this part of California with our frequent sunny days. Is that really, especially with fair skinned people, sun protection is so critical. Some of these skin cancers can grow to be quite invasive and quite deadly. So certainly, always want to be very cautious with skin protection.
So getting back to some of the treatments that you're deploying, Dr. Berkland, tell us about the microvascular reconstructive surgery as well as the robotic surgery you're using.
So so for a lot of, especially for a lot of head and neck cancer, surgery, for better or worse, is our first line treatment, and then sometimes we follow that with radiation and chemotherapy. But for a lot of patients, surgery is indicated. And so, as you can imagine, taking, if I were to take a piece of tissue from maybe your belly or from your back, you'd probably be fine. You wouldn't really notice it. But then taking that same amount of tissue from your tongue or from your throat has huge ramifications on how your physical appearance, your speech, and your swallowing. So really things that make us human. And so so if we have to take enough of a part of your body, and if we render you unable to speak or eat, that'd be devastating. So part of what microvascular surgery is transplanting another part of your body to rebuild the part that we take. So it's just like if someone were to get a kidney transplant, except that we're transplanting one part of your body from yourself to yourself. So we choose different parts of the body depending on what we have to take. So sometimes if we're rebuilding a tongue, we take a little piece of the arm or a little piece of the thigh to help rebuild that volume of the tongue. Now, we can never replace the sensation and the taste, but we can provide the structure there so that you can use the rest of your tongue and your mouth. Similarly, if we're taking someone's jaw or part of the bone of their face, we have to rebuild that bone or else it'd be quite disfiguring. And so we'll take part of somebody's leg bone or part of their shoulder blade bone to help rebuild that. And so that's where we do microvascular surgery. So these can be about 12 plus hour surgeries, so quite long surgeries.
Where did you cultivate this interest in this particular type of oncology, Dr. Berkland?
So I'd say part of it is growing up in Guam. As I mentioned, the beetle nut we had a beetle nut tree in our backyard. And so I was certainly very well aware of it. And I don't know if you know, but people chew beetle nut, their gums turn black just from the way they prepare.
Did you have relatives, family members who?
I had friends who did that.
Mm-hmm.
And as far as I had grandparents who died of other cancers, but not head and neck. But head and neck cancer was certainly well in my awareness in Guam. I actually have some research with looking back into the Pacific Island population and head and neck cancers there. It seems to be a higher incident in those populations. And so certainly that kind of drove my interest and awareness of head and neck cancer. And it's a challenging cancer. Again, it's such a morbid cancer, and we have so much room for improvement, both from a clinical standpoint as well as a research standpoint, that I thought there was a lot of opportunity for growth there. I always say that so for instance, we treat thyroid cancers too. We're actually really good at curing thyroid cancer, and survival rates for thyroid cancer are excellent. our survival rates for head and neck cancer, especially in advanced stages, isn't so good. We're talking about 50% at best at 5 years for the advanced stages. And if it comes back after that, we have a lot lower chance for survival. So there's a lot of room for improvement. And a lot of these patients are really, really thankful, grateful patients, and really need someone, need help, and are often under-supported. So certainly there's a role there for us.
Rare but very, very debilitating cancers. They're really ugly cancers.
Yeah, rare, and I would say not as rare as you think. Again, it's the 6th or 7th most common of this oral cavity cancers, or the upper oral airways. So I think a little less uncommon than you might think. Again, it's not as common as say breast or prostate cancer, but more common than some of these rare brain cancers and other kind of cancers.
Well, are there? You had mentioned some of your research just looking at like the Southeast Pacific populations, and are there any maybe new novel discoveries or, even just if you could tell us, maybe expand on a little bit of your research that you're doing in the field of head and neck cancers?
Yeah, we do a lot of research in a lot of different angles. I think one kind of broad topic we say is our research is kind of in precision medicine. Mm-hmm. And that's kind of a broad catch-all term to mean a lot of things. But what we really mean is that we're trying to optimize the treatment for each patient to the individual patient. We have these kind of broad guidelines and treatment pathways or standardized care saying, like, if this is your stage of cancer, you get this treatment. But we also recognize that different people and different cancers can behave and respond differently. And so our current kind of guidelines don't really capture this well enough. So there's a lot of interest in medicine to stratify, to find ways that really how can we personalize and make sure our treatment is optimal for each individual patient. I think this is a broad kind of topic across all cancers, and certainly one that we're interested in head and neck cancer. And so we kind of approach that in different ways in our research. One of them is, as far as precision, is like precision imaging and before surgery. So we have the Explorer PET scan at UC Davis. It's a novel technology, and we actually have a clinical trial where we use that before surgery to help us try to detect, are there lymph nodes that are involved that we might want to be suspicious about, that we want to take those out. We also have an R01 funded grant where we're actually using, during surgery, fluorescence imaging, and with the goal ultimately to help us detect what is cancer and what isn't cancer. When we think about, it's so important to save as much as we can to take out when we take out such high-priced real estate in someone's mouth, say. If we can save stuff that's not cancer, then that's great. But also, we don't want to miss cancer because then we haven't cured the disease. So it's that fine balance we have to take. So we're looking at novel technologies to help us make those decisions to enhance. Because really, as a surgeon, I'm only relying on my sight and my hands to try to detect cancer. And you think in this day and age, with all the technology we have, it's pretty amazing that that's still what we're relying on for our to make sure we get all the cancer out. We also have studies looking at what we call biomarkers. So looking at a patient's tumor and sequencing it, or even taking a patient's saliva, blood, or urine, and see if we can take markers that might help early detect cancer, or detect recurrent cancer, or kind of give us an idea of how their cancer might behave.
How many of these cancers do you think have a genetic sort of cause?
That's
family history.
Yeah, that's a good question. So as far as a family history, we don't tend to see too many of those in a lot of our like tongue and throat cancers. Those tend to be, again, the smoking. Let's say the smoking-related cancer. The smoking causes DNA damage, and then it damages a specific set of genes. A lot of them, and so there are common patterns of mutations in genes that are caused by smoking. That some genes are inactivated, some genes are turned on. And so there's large sequencing studies across all cancers, including head and neck cancer, that have kind of given we call it the mutational landscape of head and neck cancer. And there's some high impact papers that were published about a decade ago now that kind of gave us that landscape. And going back to the HPV virus, we know that HPV virus actually has specific proteins that go into the cell and knock out and shut down certain important genes that basically lead the cells to cycle and grow unchecked. So that's how we know the HPV virus is associated to head and neck cancer. So we do know to some degree some of the genetic kind of factors that kind of underlie a lot of our head and neck cancers. The challenge is that they can be so, in every individual patient, so unique. Again, going back to precision and personalized therapy, that the mutation pattern in one patient might be very different than another patient, even though similar pathways are being affected.
Dr. Berkland, because we're an academic institution, of course, and designated by the NCI as a comprehensive cancer center, we are the place when it comes to clinical trials. Do you see some hopeful clinical trials, either now or in the near future, that could help some of your patients?
Yeah, certainly, absolutely. So broadly, I think that the discovery and implementation of immunotherapy in cancers has been game changing, and it is involved in head and neck cancers too. And we're trying to figure out the right way in which to use it. So maybe that's a little before surgery, maybe it's in some combination. So that's certainly been a game changer. And so we have some of those trials at UC Davis, and again, going back to how we want to tailor each trial to the specific patient. So sometimes we are worried that we're doing too much as far as surgery. Like if do I have to take out this much of your tongue or take out all the lymph nodes in your neck when maybe we can get by with less? So for instance, we have a trial where we are testing whether for early stage tongue cancers, if we just take out what we call a sentinel lymph node, if I inject a dye in your cancer and take out the one lymph node that the dye travels to, and if that lymph node is cleared, then I can have a better thought saying like, hey, maybe we don't need to have to take out every lymph node in your neck. So we're trying to investigate that thought process for some of these early stage cancers. On the flip side, we see some very aggressive cancers we have a trial where we have cancers that have spread to multiple lymph nodes in your neck. And so what we're doing is we're giving some immunotherapy before surgery, and with the hope that actually shrinks the cancers and maybe completely resolves the cancer. So by the time we do surgery, there's not much tumor left, and that might actually lead to not needing any additional therapy like radiation afterwards. So kind of on both ends, again, trying to tailor each patient's cancer, again, to the right therapy. But certainly lots of clinical trials at UC Davis, and we have many other clinical trials, even non-surgical trials, so trials that involve different combinations of chemotherapy or immunotherapy in combination with radiation. So certainly we have trials open in kind of every kind of stage of patient, and certainly we're trying for every single type of cancer so that anyone who comes in our door might have a specific kind of appropriate trial or appropriate investigation that may be of benefit to them.
Is there anything else that we have not covered yet that maybe you feel like we need to draw attention to, or something that you want to highlight within your specific field, especially?
I think we covered a lot. I think I appreciate that you guys are aware that the prevalence of head and neck cancer and its increasing incidence, especially the HPV-related head and neck cancer, as it is Head and Neck Cancer Awareness Month. It's good to certainly kind of bring that to light, and certainly maybe overcome some of the stigma of head and neck cancer. It's been again, whether it's associated with kind of lower socioeconomic class or smoking and drinking, or maybe some embarrassment with the HPV virus. Again, I tell my patients we are all infected with HPV virus, and there's a certain unlucky few of us it didn't clear and eventually turned into cancer, but it doesn't have any other meaning behind that. And I think as more people come out and speak out about their experiences and their survival from these head and neck cancers, I think it's going to increase our awareness and increase our our collective understanding, and certainly want to hopefully move us towards the road where we're beating this to the rate that we are with, say, thyroid cancer or prostate cancer or breast cancer.
So if you have any symptoms, make an appointment. Call UC Davis Health. If you don't have any symptoms, think about getting a HPV vaccine if you haven't already gotten one. Parents out there, it's worth it. I tell you what, making sure that my two sons kept on schedule with their HPV vaccines makes me feel a whole lot better now that they're in their mid-20s. And don't put off going to the dentist, right? At a minimum, make sure you're getting your your cleanings and your exams on time, because they're going to check you for head and neck cancer as well. Thank you so much for joining us today, Dr. Berglund.
All right. Well, if you'd like to get in touch with us, you can email us directly at beatcancer@ucdavis.edu. Beat Cancer is a production of the UC Davis Comprehensive Cancer Center. For information on our NCI-designated Comprehensive Cancer Center, please visit health.ucdavis.edu/cancer.